So it's a very simple but very important topic, and I told Dr. Namrata that let the people know about it. So now there are certain scientific facts which have to be kept in mind when we deal with epiphora in infants. Number one, tears are secreted by main lacrimal gland and accessory lacrimal glands of Croppa and Wolfram, which are in the conjunctival fornix, in the superior conjunctival fornix, and very few in the lower conjunctival fornix. These lacrimal glands are fully functional by 2 weeks after birth. Accessory lacrimal glands contribute to only 10% of the lacrimal secretion we have. Though the tears begin to show by second day after birth, but they are very scanty. Eyes do not dry with these scanty tears, as the infant eyes remain closed most of the time. In 80% of cases, the lower end of NLD, which is the valve of Fastner, is open on birth. Now, why this natural history is important? A newborn may suffer from toxic, herpes, bacterial or chlamydial conjunctivitis within first 2 weeks of life, if you know that. But the epiphora is very scanty, and therefore focus should be on the disease rather than the watering. After this period, any epiphora along with any other condition which a concomitantly applies should be suspected for NLD block also. Now, what you have to look for? You know, once you have confirmed that there is this is a congenital epiphora is due to some congenital problem of the drainage system, what you have to look for is number one is the not only in NLD, you know, you have to look for the congenital atresia of the puncta or canaliculi, epiblephron, entropion, diastichiasis, structural craniofacial abnormalities, Down syndrome, non-membranous NLD obstruction, that is the cartilaginous, and the quality of these tears should be also looked into. Whether it is aqueous, if it is aqueous, intermittent discharge shows blockage of NLD due to nasal mucous membrane, swelling in URI, so that is important. If it is intermittent, watery, and with nasal problems, it should be not considered as NLD block, but an URI of the nasal one. While mucopurulent discharge goes in favor of NLDO, that is the norm. Now, once we have confirmed that it is a congenital nasolacrimal obstruction, we have to look into the direction, and that is it affects about 20% of newborns. You should have to keep in mind. Spontaneous resolution occurs in 90% of infants within first 4 to 6 weeks of age. Most studies say persistent unresolved epiphora remains in 5 to 6% cases only, which may or may not resolve spontaneously by 6 months or maximum 1 year of life. Before embarking on invasive management procedures, diet disappearance test is a good way of confirming NLDO. You know what is a diet disappearance test? You put a dye in the conjunctival sac and you wait for 5 minutes, okay? And if it doesn't disappear from the conjunctival sac or doesn't appear in the nose, which is difficult to know, but if it doesn't disappear, that means it is a congenital NLDO. Now, once it has been confirmed that it is congenital NLDO, then you have to go for the management. And this management includes lacrimal sac massage, which is a Krigler method, almost 30 years, 3 decades before. But you must, as a pediatric ophthalmologist or even a general ophthalmologist, you must know how to do a lacrimal sac massage. In most of the conditions, you know, they go to a pediatrician, and the pediatrician, you know, they advises them the wrong way. This is not the way. We don't have the time for that. I cannot tell you what is the exact method, but you must learn the exact method of lacrimal sac massage. Then NLD probing, balloon neuropathy, and we have the other ways. Now, what is important is, if epiphora does not resolve by 6 months of age, then intervention is needed. Probing remains the first line of management, and studies from various dedicated centers around the world have shown the following. Now, this is important because when do you want to probe is a big controversy. Now, the success rate of probing at 6 months to 12 months is 92%, 24 months is 85% almost, 36 months is 80%, 48 months is 70%, and after 60 months, that is 5 years, it is only less than half. So probing can be repeated 2 to 3 times also, but not more than that. It is a blind procedure, skill is needed, and the tactic has to be mastered. Now, the crux of the problem is that there is a controversy regarding the timing of probing. This is very important, and all pediatric ophthalmologists, because it comes under the domain of pediatric ophthalmology. No general ophthalmologist should try to do a probing because it has to be learned that it is a skillful process. Don't do it, otherwise we are not trained for it. Now, should probing be done as early as 4 to 6 months, which is normally many people do or think of, or should we wait for 12 months of age, which some studies have proclaimed is the last limit of spontaneous resolution? Now, the answer is as controversial as the question. Most ophthalmologists like me prefer to do it between 6 months to 1 year, except in congenital dacrocele where it is needed. Now, there are ways why the probing. Now, this is procedure which I have developed. You do the, this is the Bowman's probe, you do the probing, and this is how the probing goes. You must know the direction. For a pediatric ophthalmologist, you must know the direction of the probe, backwards, downwards, and laterally. That is very important. And then this is a fluorescent dye which I inject, and the anesthetist puts a nasogastric tube in the nose, and you see, that's another important is the amount of the saline which you are giving, because the child is under anesthesia. Okay, you should not do too much of not more than 0.5 or 0.7. You go it might go into the lungs. So this is very important. Not 2 millimeter or 5 millimeters. Now I have just it is 1. It's 1. I have just given 0.5 in the nasal cavity, and you can see it has come in the nasogastric tube. That green color has come in the nasogastric tube. So this is what I routinely do. Now, it is available in the stores here also. We don't have to use the Bowman's probe. This is a probe which is hollow, and it is a hollow at this end. See, it is hollow here. It is a hollow tube, it is not a Bowman's probe. It is a hollow tube, and it has indications 5, 10, and 20 millimeters. You do not go beyond this into the nose. Okay, otherwise you'll make a false passage. This is basically about 5 to 8 millimeters, 10 millimeters for the lacrimal sac, and another 8 millimeters for the NLT. And you don't have to take it out again and again. This is a syringe which is attached at one end with this, and at the same time, once you have done the probing, you inject this fluorescent dye, and it comes into the nasogastric tube. This is another thing. Thank you very much.
Thank you, sir, for an excellent presentation. I think we close the session because I think the next session has to start.
I'll just stand because I have to close the session and normally by 6 months the NLD length is already only thing is that it is cartilaginous, it does not have the bone. That's a different thing. But we always have 8 millimeters of the canaliculus, 8 millimeters of the lacrimal sac, and about 8 millimeters of the NLD. So normally there's only a difference of 3 or 4 millimeters after 1 year. So, by and large, it serves the purpose. But what is important is that you have to do it very meticulously. You must note it, because I have seen many, when I was teaching my residents, they just to, just to push the probe like that. No. And this another thing, I have, there are 2-3 theses of it I have done from my residents, how to, this fluorescent dye method is also which I have devised, and a lot of people are doing it. The only thing is that you must know the amount of fluid which you are injecting inside, because it is under GA and the child can aspirate. So that is very important. Not more than 0.5 ml to 0.7 is enough to come into the gastric tube. And the other thing is, you must know the direction. That is very important. The direction of the probe which you are doing for the NLD opening. And one last thing, if you should not have any noise, because when I do this thing, I tell everybody to keep shut in the OT. You can hear the pop. When the valve of Hasner mucous membrane is pierced, you can hear a very small faint sound. If you can't hear the sound, you can feel, the loss of resistance. As you are going, and go very slowly, gradually, and that's why the direction, the markings are important. Don't go beyond the third marking. And as you are reaching the third marking, be very gentle, and you can see the disappearance of the resistance.